Welcome to Destination Change, a podcast where we talk recovery, treatment, and more. I'm your host, Angie Feather-Sutton, with the National Behavioral Health Association providers, and I use she, her pronouns. My guests today are Chris Wolfington and Pete Nielsen. Chris is the founder and chief revenue and strategy officer of FinPay. He has more than 31 years of experience in technology, healthcare, payments, consumer, and financial services companies. He is determined to utilize his talents to positively impact these industries. With a keen sense of leadership, Chris has used his passion, energy, and capital to lead numerous businesses in the areas of payment and financial services, including 3 public companies. Our other guest is Pete Nielsen, who longtime listeners might remember from episode 2 of this podcast. Pete is the president and chief executive officer for the California Consortium of Education Programs and Professionals, CCAP, CCAP Credentialing, CCAP Education Institute, and the National Behavioral Health Association providers, NBHAP. He has worked in the substance use disorder field for 20 years. In addition to associate management, he brings stable experience as an interventionist, family recovery specialist, counselor, administrator, and educator, with positions including campus director, academic dean, and instructor. Take it away, Pete.
All right. Thank you, Angie. And I got to set the stage here because, I'm in an office environment. I have a tie, I have a collared shirt, and then we have Chris, who looks like, he just got hired for the militia and has this black hat and black sweater on. So,
it's a jacket. You just can't see it, Pete. It's a jacket.
Okay.
And this has an Philadelphia Eagles logo on it, which, by the way, for those that don't know, we did win the Super Bowl. And I say we because I'm from Philly. Well, you know what's interesting? It's funny. Some people say to me, all right, FinPay is the only electronic financial records technology in the market. You guys have a monopoly. Isn't that great? And I say, well, it sounds great, but it's actually not great because nobody's used electronic financial records at a level that it's as common as an EMR. And today, if a treatment facility wanted to start and not have an EMR and tell their clinicians, oh, you're going to use paper and spreadsheets to manage their charts and get claims paid, everybody would think that place is nuts, right? But there was a day,
right,
before CMS mandated electronic medical records where people use paper and spreadsheets for charts and to submit claims. And so back then, clinicians would be like, I'm not using some computer. My notes are great. My system's great. And there was a learning curve but today, you'd be laughed at if you suggested don't use electronic medical records. So the same is true with electronic financial records. So think of it this way, Pete, and I try to explain this, but when you have a monopoly or you're first to market, the challenge is this. I say to somebody, 20% of your revenue is owed directly by the patient, right? So rates are coming down. We all know that. The out-of-network model is sort of under attack. But more and more of the rate that you're entitled to is owed by the patient in the form of deductibles, copays, and coinsurance. And people are managing that with paper and spreadsheets, but they just don't know any better.
Right. So
part of the difficult thing about being the only electronic financial record system in the market is trying to explain to people, this is really important. Like if you want to track that portfolio, that portion of your revenue, that's 20% of all the dollars you're owed, and how you track that across multiple departments and how you collect that money and how you make sure you're compliant. Because as you know, ECRA, since 2018, the Elimination of Kickbacks in Recovery Act says it's a criminal offense not to collect that money, and payers are being more aggressive with audits. And if you show up at an audit, Pete, imagine with the associations and the organizations you're involved in, could you imagine showing up to a payer audit with paper and spreadsheets to substantiate that you're innocent of inducement, right? That when you show someone, oh, here's my good faith estimate, it's on like a piece of paper, maybe I did an Excel spreadsheet, right? Like you're not going to win that. But because there are no subject matter experts that work for the organizations that I speak with, like the CEO can't know everything. So normally, if a billing company came in and talked to the CEO and said, hey, I want to sell you my billing services, the first thing he would do is go to his CFO and say, hey, this billing service is here. How's our billing service doing? Should we talk to these guys? right? He would rely on his expert to tell him, is this a service that we should consider changing? Well, you go in and you say, who's your patient financial management vice president or director of patient financial management? He looks around and goes, am I supposed to have one of those? like, I don't have one of those. Or they go, hey, admissions guy or admissions woman who has enough things to worry about. I'm going to throw that on your plate. Or, hey, revenue cycle manager, I know I beat you over the head to get the claims paid efficiently and at a high percentage, but I'm going to throw patient responsibility and patient financial management on your plate. And now that person's going, look, I'm stretched thin as it is getting these claims paid, and now you want me to deal with the patients on what they owe? So my challenge isn't the need for automating this part of the business. It's no one's ever managed it or automated it. Does that make any sense?
Right. No, and this is where you come in when you're an innovator versus an imitator. You come in and
whoa. Say that again. Wait, say that again.
Yeah, you're an innovator instead of an imitator. So when you're an innovator, you have that burden of educating the public, educating the consumer that your product, this is what it is. So anytime you're cutting edge, that is the burden of responsibility. The problem is at some time you will get the imitators and they will feed off your coattails. So, this is the problem that I always have when I innovate, is that it's great, except people don't understand the product, the service, what you're trying to do. And you spend a lot of time on that education. And then when you start to educate the public or the consumer, then the imitators come along and then they can ride the coattails. And, so that's always the hardest thing when you're an innovator and doing something like this where people don't really understand, and especially since, ECRA, about patient responsibility. I mean, we have a toolkit in behalf, for patient responsibility, and you think that would be the number one seller, but people don't think of that as a first thought,
And here's my metaphor I always use for that. So if somebody owns a Toyota and they walk into a Honda dealership and the Honda salesman starts talking to them about the value of a Honda, how much it costs, the features of the car, the different colors it comes in, immediately that person in their brain, whatever they're hearing from that person, the Honda, comparing it against what Toyota, which is what they currently drive. In other words, there's a bucket in their brain that they associate with cars and their personal experiences. So anything they're hearing from the Honda person is always being measured against those prior experiences. What's interesting, to your point, I think, in this case, we're talking about patient financial management. And just as I define that, Pete, I define patient financial management as the strategy, the policies, the workflows, and the technology that is used to manage the economic and compliance risks associated with patient financial responsibility. And patient financial responsibility takes the form of private pay patients that just pay cash, or insured patients that have deductibles, co-pays, and co-insurance, sober living, rents, right? Anything where a human being, a consumer / patient, has to reach into their own pocket and pay all or a portion of the services. So I just because I'm going to use those acronyms a lot, I say PFR a lot for patient financial responsibility. So just as you and I are just chatting away here, so people know the context. But when you go in and you talk to someone about patient financial management, their brain is like searching for a bucket, right, of experience that they have. And normally what people will say to me, oh, you're a payments company. Well, we do payments, but we're not a payments company. Oh, you're a billing company. No, we don't have anything to do with the claims. It's all about the patient. Oh, you're a collection company. No, collection companies are what you're doing now when the claim adjudicated and it's now 120 days after treatment and you're trying to chase the patient around for the money they owe you. That's the challenge that we always have. And what I think's interesting is most people in this industry, in the business, they just think of patient responsibility as that thing that used to go, shh, don't tell anybody, but just come on in. I'll let you in. Don't worry about that money you owe me. because I just want to get the insurance claim paid. And 10 years ago, Pete, I'd be a hypocrite if I didn't admit that made sense, right? You had a huge out of network models out in the marketplace. People were making enough money off the insurance, and they always in their head were going, well, the guy down the street's not collecting that money, so I don't want to lose the admission by talking about money, so I'm just going to ignore it. And that was well and dandy, but two things happened. One is you and I just discussed. ECRA was passed, right? So now it's a criminal offense, not civil, criminal, not to collect that money. Second thing that happened was high deductible health plans hit the market at a very accelerated basis. And so when that 10 years ago, the patient owed maybe 2% of the bill. Now they owe 20 to 23% of the bill, right? I've seen some as high as over 25%. So think about it in this context. How many businesses, Pete, do you know of that can have 20% of their revenue never get paid and still build a sustainable, viable business, especially in network? I'll argue you can't. And then there's other supplementary things that people don't think about. I'd love to get your opinion on this. There's a ripple effect that this part of the business impacts. So let me give you an example. I'll give you three right off the top that I think are huge. One is, I would say 95% of the market, their patient financial management strategy is the following. Run a VOB, maybe even do a live VOB that your billing service or your billing staff does. Just store that somewhere in the EMR. Let's wait till the patient discharges. And after the claims are adjudicated, we'll send them 3 statements because we think, falsely by the way, that 3 statements makes me compliant with ECRA. It does not. Statements do not count as a regular and customary collection effort in and of themselves. So now think about what I've just done. I don't think anybody on this, listening to this, or you, Pete, would argue that the relapse rate in the United States is over 50%. Would you agree with that statement?
I'm not going to disagree with it.
You are going to disagree?
No, I'm not going to disagree because I don't know if let's go with that. Let's go 50%.
Let's call it 50 just to make my point.
Yeah.
So if I have 100 patients go through my facility and my patient financial management strategy is to send them a bill for thousands of dollars that's going to arrive 60 to 90 days after they discharge from treatment, that no one helped them with, no one told them was coming, knowing that one of the leading causes of relapse is financial stress. So the fact that a treatment facility would have a patient financial management strategy that literally triggers what is commonly accepted as one of the top 3 causes of relapse, financial stress, seems absurd to me. And then I'll add to that. When that's your strategy, 100% of your patient's last experience with your treatment facility is financial, not clinical. That strategy I just articulated, that means the care is first and the bill is second. Right? And so if that's your strategy and patients get unannounced multi-$1,000 bills in the mail shortly after treatment, well, think about what that means to your alumni strategy. When that 50% of that population relapses, I don't know where they're going. I only know where they're not going. When that alumni population has a family member or friend that needs treatment, I don't know where they're going to refer that family member or friend. I only know where they're not going to refer that family member or friend. So if the financial experience is allowed to be that horrible just because people don't know how to manage it any other way, think of that ripple effect. I'm not getting paid what I'm owed. I'm possibly triggering a relapse for the very person I was paid to help protect and to get well. And 3, I've killed any chance that alumni is going to be a brand ambassador and refer me to family members and friends. And if they relapse, they're sure as heck not coming back to me.
But I think I think that, one of the issues that we have in treatment is we don't look at payment as a clinical issue. And everything that you're saying is really puts it in the realm of a clinical issue, for individuals, and thinking about that's a part of their care. And from another perspective, that for helping somebody regain their lives and change their lives, taking responsibility, and being able to improve their life, part of that is financial,
Yep.
and being responsible.
And I'll give you a great example, a further step on that, or to support that. So one of the misplaced sort of fears or apprehensions I'll hear from somebody. So let me give you some data first. And I can show this. I have a chart for this. If anyone follows up with me, I'll get it to them. So FinPay as a company, we've managed about 500 million or more. So over $500 million of this risk for over 100 treatment facilities representing 220,000 plus patients. And here's the data. If you talk to a patient prior to admission and have a fair, accurate, honest conversation about cost, they'll pay you 76% of what they owe. If you wait till they're in treatment to have that financial conversation, you'll only get 50% of what you're owed. If you wait till they discharge, you'll get 35%. And if you wait till the claim is adjudicated, you'll get less than 20. That is the math on $500 million worth of data and 200,000 patients worth of data. Now, here's what else was interesting, Pete, we learned. The patient satisfaction score, when the financial conversation had up front, and I'm going to explain what doing it right means, like having it fair and honest and transparent. Because it's not just, oh, you owe me the money, how are you going to pay me? That's not what I mean. But when it's done right, and I'll explain what that means in a second, the patient satisfaction score across that population, 200,000 plus patients, was 97.2. So let me compare the first two things I just shared with you. What's the collection rates and versus what's the patient satisfaction score? So the average collection rate of behavioral health on patient financial responsibility is only 13 to 15% across the entire market. Our clients get 70. The patient satisfaction score, people using our automation tools, 97.2. It's less than 5% across the whole market. Now, here's a data point that I wasn't expecting. Unfortunately, I can't tell you why this is, but inpatient patients stayed 3.05 days longer when they were engaged around cost up front. My theory is that if I go into treatment the day I walk through the front doors and my fears and anxiety concerns around cost are already in the rearview mirror because I've already handled it, why would I leave early? So getting back to your clinical connection, right? Like nobody thinks to connect a dollar somebody owes to how it would impact their clinical outcomes. Well, I think everybody listening to this would agree that a higher dose of treatment produces better outcomes. So if someone doesn't leave early, they have a better chance at more sustainable recovery. Secondly, if somebody doesn't have any fear, anxieties, or concerns about cost, now they have skin in the game. Now they have a responsibility factor. Now they're not going to get triggered by financial stress when a unannounced bill shows up. All of these things affect clinical outcomes. And if anyone listening to this believes in social determinants of care, of impact clinical outcomes, well, then this is even more relevant, if that makes sense.
No, it does. And I think that when you bring somebody up to your facility, you're supposed to have informed consent. Informed consent includes all the stuff clinical, but also financial. So they know the full package. And to your point of skin in the game, when I used to run facilities, I used to run treatment, I don't know if you knew that, I used to run treatment facilities. And I'll tell you, the ones that would come in and they were indigent and they didn't pay any money and they came in, they would come in and they were just behind the Kentucky Fried Chicken, eating garbage scraps. And, 2 days earlier, they would come in 5 days later and critiquing the food, critiquing the pillows are too soft. They were sleeping on bricks and concrete. And then, and I think, and then they were more likely to AMA. Why? I believe that, and to your point, that once somebody has skin in the game, meaning that they have something invested, they put something in. It doesn't have to be a lot. It has to be.
I'll tell you, I was going to say, even if it's $10,
it's something in there, and it's tangible. And here's the thing, when people are in their addiction, everything's very tangible. Money and finances are very tangible, and they're thinking, you know what? If I blow out of this, that's money that's gone. I don't want to lose that money. And people do have that thought process. I've had conversation with lots of clients. I'm like, why'd you stay? And because, well, I knew, one, I'd be disappointed in my family, but the other is that that I already paid for it, and that money what am I going to do with it? I would rather, see what this has to offer, even though I'm not totally bought into this whole recovery thing, but I will finish this because it's going to cost me, if I don't. And I think that having that responsibility and skin in the game really changes the dynamic. And I think clinically, you're less likely to have clients to have negative perceptions and feelings about the organization that help save their life if, they feel secure in that financial picture. And
I'll go
trust somebody. Well, hold on, Chris. How do you trust somebody if you feel like they're taking advantage of you financially? You don't. How do you trust the clinicians? How do you trust any of that? If everything's up front, you got all the money and the finances, and they treat it seriously, and they're not just a wink and a nod and letting it go by, you trust that institution even more. And what's the number one thing as a match? The match studies back in the 70s or 80s, it said that therapeutic alliance. That, I think, aligns them with the clinician and the agency with that therapeutic alliance, because they can trust what they say, they feel secure, and that, and when you do wink and a nod stuff and not take it seriously and kind of say, oh yeah, we'll take care of it. It feels like it is when they're out there using that whole mentality, and that there's nothing changed in that. When the facility acts responsible, it helps the individual act responsible.
Yeah, they feel like they're getting over on you because no one asked them. They know they owe money. You know they owe money. Let me ask you a question, because I want to sort of talk to you about what I call the right type of financial engagement versus the wrong type. What do you say to the treatment facility owner, or probably more relevant, the director of admissions at, ABC treatment, if they say, you can't talk about money, you'll lose the admission, or you can't talk about money up front because the guy down the street, he's letting him in without having to pay anything. So I'm going to lose my admission to that person if I even bring up money. Now, I have an opinion on this that I'll share in a second, but I'm curious, what would you say in 2025? Not the guy from 10 years ago, because he'd probably be right 10 years ago. What do you say in 2025 to the admissions director that thinks that?
I think that they need to disclose that, and I would think that they're wrong by not. And you know what? That's the same as saying, we're not gonna do any difficult feelings or anything challenging in treatment. We're gonna make sure that they don't have any care in the world. And you know what the problem is they're setting them up for failure, because they're not, they're really doing benign treatment. So when you say, oh, well, let's let this slide, or let's not talk about it, or I think that's irresponsible in my book. And, letting people know what to expect up front. Same thing in treatment. It's not all going to be comfortable. It's not all going to be roses, and it could be painful and difficult getting through the process. Same thing with finances. I think that the agency owes the client to let them know the costs up front, because other than that, it would be bad treatment. And I'm not even saying just bad financial. I'm saying bad treatment. If they don't discuss what the impact or what the finances up front, they're misleading and lying to the client. And that's not a good relationship to start.
It's a horrible way to start. And I would agree. Not only do I think it's irresponsible, but as we discussed in the beginning, since 2018, it's criminal.
Yeah.
To not collect that money. But here's why I asked the question.
So you have ulterior motives. That's me.
Yeah. Well, no, I want to delineate between, we're just talking blandly, right? We're saying talk about,
right.
Right. We're not drilling down into what does that really mean. So let me give you the scenario that's the wrong way, right? Hey, Pete, I just ran a verification of your benefits with your Aetna policy, and you have $1,000 remaining on your deductible. How do you want to pay that today? Well, that's the wrong way to have the conversation. Number one is you haven't earned the right to ask for money yet.
Right.
So you don't ask for something you haven't earned. Two, there's more than just the deductible. There's the coinsurance. So in essence, if I just try to collect the deductible, because that's the only quantifiable number I have, I'm misleading the patient. Because if I paid that $1,000 when I was told, what do I think? I think I'm done.
Right.
I think I paid you everything I owed you. And then when a bill shows up for $2,500 in the mail because of the coinsurance, I think you lied to me. I think you bait and switched me. And now I've hurt my brand. So let me roll. If you don't mind, Pete, I want to role play with you a little bit, because in our software, we have this scripting, and it's dynamic scripting. In other words, we look at the data from the CRM that we got, and it tells me a lot. It tells me if you're an in-network or out-of-network patient. It tells me if I'm talking to you pre-admission, during care, or after. It tells me how much you owe if you've used our estimator tool. And people that owe a lot of money need to be talked to slightly different than people who have a smaller dollar amount. And the scripts are dynamic and unique to the different, what we call risk classes. And each risk class is separated by what we call the different situations. So I'm going to pretend, Pete, that you're an in-network patient, and I'm going to share with you a little bit how we train people, and they push a script button in our software, and the right script that's relevant to the exact type of patient shows up. And it might sound something like this. Hi, Pete. My name's Chris. I'm the patient engagement specialist here at ABC Treatment. Before we get going, Pete, I just want to let you know that you should be really proud of yourself for making that phone call to ABC, because it really is your first step in your journey to recovery. You should be very proud of yourself for that. So right away, it's not about money. I'm just trying to help you. And by the way, I'm the dedicated person at ABC Treatment that talks about money. The admissions person is now off the phone waiting for the next call.
Right.
So then I say, Pete, I want to tell you it's a really good thing that you called ABC Treatment, because we genuinely care about your financial health, not just your physical health. And every one of our patients gets free access to an engagement specialist like myself to help you navigate your costs for treatment. And the reason we do that, Pete, is most people don't understand that ABC Treatment does not determine what you owe. 100% of what you owe for your treatment is determined by your Aetna policy. Did you even know that, Pete? And most patients say, no, I didn't know that. And I say, well, most people don't know that, Pete. And my job is here to help you navigate the policy that you picked and the policy that you have. Does that make sense?
Yes.
And my goal today, Pete, is to not only answer all your questions and make sure we're fully transparent with you about cost for treatment. I'm even going to help you get into a payment program today that you feel really confident and comfortable that you and your family can afford and won't have a negative impact on your family budget. Does that sound like a good idea, Pete?
Yeah.
Okay. And another thing, Pete, that I found that's pretty consistent amongst all the patients I speak with, the people that have a good support network, and you might tell me your mom, your brother, your sister, your friend, whoever, and every name you say, Pete, I'm writing that name down. Now, the next thing in the script, I won't go through the whole thing, but I might say to you in a couple of minutes, Pete, a lot of people get frustrated with healthcare costs because it's hard to understand, and they don't understand the billing and claims process and all the mail that's going to show up. You get mail from your insurance company, you get mail from us. Do you mind, Pete, if I take a couple seconds and explain some of that to you so you don't get frustrated? Everybody says yes. When we monitor the calls, they're like, sure. So we explain what the scripting explains what an EOB is, explains the difference between that and the statement, explains that it can take 30, 60, 90 days for all this paperwork to catch up. And then I say, Pete, does that all make sense to you? Like, I don't want you to get overwhelmed when all this mail shows up. Do you understand how the billing claims process works? You say, yeah. And I said, another good idea, Pete, for me to cover with you is, there's some things you can do to save money in your treatment. Do you mind if I share some of those ideas with you? And what do you say? Sure. And I'll explain to you what an FSA is and an HRA, right? And an HSA. And I'll explain to them and say, hey, depending upon your employment, you may want to go to your HR department, find out if you're eligible for any of these programs because you could save a lot of money and pay for your treatment on a pre-tax basis. And then I'll get into, hey, Pete, I see you have an Aetna policy. A lot of people find these policies confusing. Do you mind if I take a couple minutes and explain how your specific health plan works and how Aetna determines what you owe? Notice what I said, how Aetna determines what you owe.
Right.
Now, I'm paraphrasing some of this stuff, Pete.
Right.
But what have I not done? I'm a couple minutes into our conversation, and what have I not done?
Ask for money.
I have not asked you for a dime. What I've been doing is helping you. Pete, you want to learn how to save money? Sure. Pete, you want me to explain the billing claims process so you don't get frustrated? Sure. You want me to explain how Aetna determined what you owe? Sure. I'm a helper. I'm a navigator. Now I say to you, Pete, it's a good thing. Last thing I want to cover with you is at ABC Recovery, we want you focusing on getting well, not on affordability. And we have several great payment program options for you to help make treatment as affordable as possible. And then I would go in and I would explain, and the software lays out on the screen exactly based on the business rules of the people that own ABC Treatment, exactly what payment programs that are available to them based on their situational risk. Now, I know that was paraphrasing and I know I was cutting that short, but that's a whole different level of engagement than just saying, Pete, you owe me $3,000. How are you going to pay that today?
Here's what I look at that, Chris, and this is what I look at. So for me, in my life, it's better to pay with cash than credit. In the sense, it's better to be upfront and honest rather than tell people what they want and to appease people, and then later pay the price with interest because you weren't upfront and honest with them. And that's how I look at this: is you're really paying with cash, so to speak. I mean, no pun intended, really, but you're really paying with that because then you don't have to. Somebody understands what they owe. They understand, who's paying with the whole responsibility. You know how many times that would all get messed up in treatment. These conversations of this stuff getting messed up happens all the time, and people leave. There's AMAs because of that. Yep. Because there's a misconception of who's paying. Or here's the other thing: is what's a great excuse to leave treatment is saying, well, they lied to me. They didn't tell me everything up front. So forget this place. I'm going to go to those ANA meetings and I'll be fine.
Yeah, and then they get the bad reviews. This place only cares about money. Blah blah blah. And it's funny. It's interesting that you went down that path because I agree with you. From my perception, what we just did is created a software that automates and takes all of the guesswork out of the best way to engage. So I don't know if I ever showed you, Pete. It's actually really cool. We built this estimator tool that integrates with our client CRM, and I can grab their VOB and automatically create an estimate that'll say, this is the revenue you'll generate if you approve this admission. Here's the percentage of the money that the patient owes. Here's the actual dollar amount. And here's the breakdown of what portion of that was deductible, copay, coinsurance. So when they're talking to the patient, not only can you do a better job of engaging, you're using really accurate information. And so the patient feels even better that, hey, these guys know what they're talking about and they're being really clear. And when someone gets into a payment program, you literally push a button in the software, and electronically sends out the documentation. So you're compliant with ECRA and you're compliant with consumer protection laws. And all the patient has to do is click an approve button on their cell phone and all your compliance documents are signed. So what we just did, because I passionately believe in what you just said, if technology can make your employee do a better job of having an engaging, transparent, fair financial conversation that not only secures the admission, but extends the value of your brand because no one else is doing it that way. And if you're worried about them calling the guy down the street, trust me, when you do that type of conversation, they called the guy down the street and the guy down the street is doing the bait and switch and ducking the entire financial conversation. People aren't stupid, right? Like we talk about car salesmen, right? The bait and switch, everyone has like, or the insurance salesman, right? Like treatment has the same way. They're bad actors in this industry, sure. But the people that do it right, the clinical outcomes are better, the financial outcomes are better, the compliance outcomes are better, right? And then you have a more sustainable business. And I'm just a big believer. Yes, I'm a little biased, right? Because like but I really believe it.
But halfway through you talking, I just had a big smile on my face, and I'm like, oh, I just figured out FinPay's tagline. I'm like, boom, there, I got your tagline. I need royalties for this tagline.
Okay.
Anti-patient brokering software. Boom, there you go, drop in the bucket, because everything that you said really, really gets to the bad actors in the industry of, this real unscrupulous, hidden, and nobody really knows what's going on with these patient brokers. And basically you have a transparent system so that everybody knows. How do you know that somebody isn't going to a patient brokering organization? I'll tell you, having transparent financial information is the anti-patient brokering inside of an agency. How do I
You're
know?
right. If you're truly patient brokering, there's no way you're going to do that, right? Like,
no, absolutely not. You don't want to be transparent.
I never thought of it that way. That's an interesting.
That's why you keep me around, Chris. This is why you keep me around.
I keep you around because of your bubbly personality. That's why I keep you around.
Well, hey, so I want to transition on us and kind of, how we got into this, because I think you tell the story, because I've heard it 3 times now, best, so I'm going to set us up. So we're at this networking thing, and I've known Chris for years, just walking by, and we've had a couple conversations, but nothing really strong and engaging.
We were at a conference. It was a conference.
Yeah, and we just seen each other at different conferences and stuff, but so I'm trying to find a place to eat, and there's not a lot of places, and so I happen to eat at this table, and it's right next to Chris entertaining some people at this nice little fire, and I'll let you take it away from there, because
I'd smoked my cigar and I was relaxing. Well, no, what made it funny, Pete, was as I'm talking to the people I was chatting with, I noticed that your back was to me, but I noticed it was you. And a couple times I was seeing if I was get your attention to say hello. But because I'm engaged in the conversation, I don't go there, right? Unless it was, you present the option. So we're talking about all sorts of stuff. I love conferences because I get to meet some really insightful people. My attitude in life is always, you're always learning. The day you stop learning, you're dead. So I'm always interested in ideas and thoughts people have. So I'm in this great conversation, which clearly it was great because at one point you couldn't help yourself. You were done eating. Pete stands up. Now I have to understand, his chair is his back is to me, but I could literally, my arm was twice as long. I could have tapped him on the shoulder. That's how close he is to me. Well, Pete literally just stands up, flips his chair back so now it's facing me, sits down and goes, "Oh, hi, Chris. Mind if I join you?" And I'm like, and I said, "Hello." And you're like, "Well, you've met me before." I go, "Pete, that's why I'm saying hello." And then he got involved in the whole conversation. And then you and I, this kind of spurred this. You were telling me about some of the stuff you were doing, some of the podcasts and some of the great things your organization does out in California. And you and I embarked on an hour-and-a-half conversation, Pete, that I was telling people when I got back in my office. I could have gone on for another 2 hours with you. I mean, you and I got into some really cool, I think, industry-leading discussions and thinking. And it went like this. It just flowed. And when you were talking about getting on it's like, well, I have someone else do the podcast. I'm like, Pete, you and I need to have these conversations. He and I it was like smooth. I mean, it just rolled. And I love the conversation, just like this is going. It's fun. I'm having a good time. Think about it. An hour's almost gone by, and it seems like we've been on here for 5 minutes.
Well, and this is why I was engaged in the conversation, is because Nobody's talking about the patient responsibility. We have a toolkit, you have software, but really the conversation is much deeper than all of this. More deeper than any of this is that what I think is really would fix some of our problems in the industry that we have, you know, patient brokering being one of them, AMAs being another, distrust of treatment facilities, that there's clinical and business and all rolled up into this issue that we're talking about. And that's what really intrigued me, because you were right. When you were talking and I was listening, I was like, he's absolutely right. And I've never really heard you discuss in detail about all of this. And so, when I was listening, I'm like, yeah, I mean, there needs to be an honest discussion about patient responsibility that is not shortened and is not treated as a checkbox. It's actually part of the full care for the client treatment. And that's what I heard. What you were saying, that's what I was hearing was, wow, this would benefit the client. I wasn't really looking from the angle of the facility and the business practices. I was really looking at, this is really sound practice, for facilities to be responsible and then I also thought, wow, if facilities do this, that they could actually increase the amount of money they make legitimately, honestly. Wow, this is a game changer. Not knowing, just take out the software, just doing this practice, they could increase the amount of money they're making. They can increase patient satisfaction. And I'm like, it just baffles me that, one, nobody's talking about it. And
that's the weirdest thing, Pete.
Yeah.
Nobody,
it's a no-brainer to me,
talks about it. I go to I want to hear a crazy statistic. Crazy. This is insane to me. 20% of the revenues owed by the patient go to any conference in the United States in the last 7 years. And there's zero conversation about best practices. What are the consequences of doing it right? What are the consequences of doing it wrong? What are the just open dialogue? Everyone puts their head in the sand and pretends it doesn't exist. And I'll go a step further, something you just said. Strategy is important, but if your strategy is, I'm using paper and spreadsheets to manage this, that is not a strategy. That's a destiny for failure. If your strategy is, hey, Mary or Joe in the admissions office, tell the guy they owe you $2,000 and ask him how he's going to pay for it. If that's your strategy, you're going to lose, right?
Right.
Or if your strategy is what most people do, put your head in the sand, send them 3 statements, hope I never get an audit because that's not compliant, and maybe I'll cross my fingers and somebody will pay me. But all of these things, Pete, is why the national collection rate in substance abuse and behavioral health is 13 to 15%. That's absurd. And so there is a right way, to your point.
Mm-hmm.
There is a way you can get your cake and eat it too, which means you have fair, honest conversations that build up your brand, that add credibility to your brand, where you get paid, where patient satisfaction scores are literally through the roof. Better. Our clients, want to hear crazy? The financial experience satisfaction scores for most of our clients are higher than the clinical scores. Think about that. I have a testimonial. I show it every time I talk to a customer. And I kid you not, this is a note that the patient wrote to us. This was the greatest financial transaction I've ever done. I'm extremely happy. So think about what she said. Paying for my drug and alcohol treatment before I even got there was the best financial transaction I've ever done. I'm extremely happy. We get I call them love letters, and the average client gets anywhere between 5 and 10 of these a month. Some of the bigger clients, maybe 15 or 20, where patients are literally or family members writing notes because they're so shocked at how great the financial experience was, because normally it sucks.
Right.
That they feel compelled to write a note about it. Who the hell would ever think that? And that's what I love. That's the part I love.
This should be common practice. This should not just be a rarity, but it should be common practice, and facilities should do this just as common practice. And put your software, aside from that, they should be doing the practice.
Yep.
Software is good, but the practice is key, and they're not doing that. And the nice thing that I can say, and I'll do a little plug for your software, is it's plug and play, and it makes it easier for the facility, and it's really a training tool for their staff. So you really get a lot with it. And I only know just from having, engaging conversations, but I am going to start to, because I know it's time for us to kind of wrap it up, and I'm going to kind of change the conversation a little bit, kind of move us into, and I'm just curious if, you have all these other opportunities in the world to do. So you're a person in long-term recovery. Why are you doing this? Why are you not, killing it on Wall Street or have 14 other companies? Why are you doing this, Chris?
So FinPay is my 7th startup. So I just turned 60, Pete. I'm showing my age. And this is the 7th startup. But I say startup, I mean literally from my basement, right? Like kind of thing. And you're going to laugh at this.
Yeah.
So I get sober. I go into this place called G&G Holistic down in Florida. It's not in business anymore. They sold it. The people that bought it closed it down or whatever. 2 great guys owned it. Jerry Goldfarb and John Giordano. I throw them a shout out.
That's why it's G&G.
Yeah, they saved my life, right? And I'm very grateful for that. But I had means. My story was a little different. I actually had successful companies, and I was making a lot of money. It just goes to show you money doesn't solve problems, because
I'm shocked, Chris.
I know you're stuck. I was spiritually and emotionally bankrupt at the time, but I'm a business guy, and I always am intrigued by how businesses work. So I'm literally in treatment, and I'm noticing that some people that came after me have already left before me. And I remember I got to know the owners pretty well. And I said, what's going on? Why did Mary leave? Why did Steve leave? And they were saying, well, they couldn't afford to stay. And, we have some people we scholarship, but we can't scholarship everybody or we wouldn't have a business. So going on, it so happens to be at that time I had a company that did payments in the casino industry. And part of that was we lent money to gamblers called markers. And we did a lot of that. And my bad debt on that was really low. So I went to Jerry and John after I got out of treatment. I said, guys, so 2 things happened. For those of us that have gone through recovery and you do it successfully, you follow the steps, you have a sponsor, you do all those right things, and you get that happy and joyous free thing that the big book talks about. It really is true. It's happy, joyous, and free. And it's a new kind of high, and it's a new type of intoxicating. Mine manifested itself in a very bizarre way. I was so excited about being sober that in 1 year out of treatment, I scholarshiped 8 different people, 6 of which, Pete, I didn't even know who they were. And I quickly learned, this is not a good model. Writing checks to send strangers to treatment, that's not going to last long. I'm going to run out of money. And so then I went to Jerry and John and I said, hey, I got this business that lends money to gamblers. We use technology to do that. I said, what if I lent your patients money? What if I made a way to, just like cars, right? When's the last time you saw a car commercial that showed the price of the car? No, they show the monthly payment. So I said to them, I'd like to work with you guys. I'd like to get more people in treatment. Meanwhile, so this is like a side thing from my core business. And then I have a strong faith. I believe God didn't want me in that other business. And I ran into some healthcare scenarios with family members, one of which was a family member that needed treatment, one of the 8 people I paid for. And I just realized, wow, this is huge. And I started doing research, Pete. You want to hear some crazy numbers? Last year, there were $490 billion in copays, coinsurance, and deductibles, and only 19% of it ever got paid. That's the entire healthcare industry. And in behavioral health, it's $50 billion, and only 13% of it gets paid. So I'm like, that's insane. And I remember, because I go to a lot of meetings, you talk about people about financial stress, and then you'd hear people bitching about like, oh my God, I couldn't afford treatment. And I'm like, I know this is going to sound corny, but I was like, I can solve this problem. I literally can solve this problem. It's Recovery Centers of America, which at the same time I was starting FinPay, they were a brand new business. And they were growing so fast that as I was learning with FinPay, the little nuances to make things right the way it is today, to really button up the software and how to talk to patients about money and how to do an estimate through technology and how to, have visibility, all the things that make our system great, in my opinion, was only really possible because early customers like Recovery Unplugged and Recovery Centers of America, give a shout out, were like, they drank the Kool-Aid. They said what you said, Pete. We want to be great at this. We don't want to be good at it. We want to be great at it. We want a patient to look at us in high esteem, whether they're looking through a clinical lens or a financial lens, because both of them impact their recovery. And so the management at Recovery Centers of America, the ownership and management at Recovery Unplugged were like, no, it was like you, Pete. It was like, I was here to make this guy, Rob Harrison, is great. I've grown to become great friends with him. He said to me, Chris, there's only one right way to do it. You do it up front. You do it transparently, right? You have a dedicated person talking about money, so they're a pro at it. It's not a part-time job for somebody. And he's like, and your software just helps to automate it, make it really easy. And when you have early customers like that taught me as much as I taught them, I mean, I can't tell you how many times I'd be in conversations with both of the management of those two businesses, and it'd be these great collaborative exchanges. And our company is great today because of our customers, like giving us that kind of really valued feedback. And that's why I tell everybody in the company today, if you think we're there, like that's the scariest thing in the world. I never want anyone at our company to think we've arrived, because we're always learning. And that's sort of how I got here.
Well, and we're wrapping up because I think it's time, and we could go on for hours. We can definitely.
I'll call you when we're done and we can keep chatting.
And talk about this stuff. So, so I think it's really great, to have this conversation. We didn't know where it would lead. We just knew that we needed to have a conversation where other people can listen to us have the conversation, because I really feel passionate about it. And obviously Chris feels passionate about it, and bring awareness to this issue, more than anything, more than my organization or more than Chris' organization. If we can get more facilities to do this, we can increase the satisfaction by patients, and we can increase, the business practices and help get rid of, some of the scandalous actors. I really, truly believe that having good practices, business practices, can do that. And, I was smiling on the inside when you're talking, Chris, because I'm dealing with a lot of, anti-treatment legislation on a daily basis. And I was just like, if somebody can hear what we're talking about, that's not from this industry that believes that there's bad actors and people trying to sham and okey doke people, listen to this conversation where we're talking about being open and transparent. We're talking about being that anti-patient brokering, philosophy, and really looking at, doing that. I think that people would change some of their minds on treatment, because unfortunately they have way too much experience with some of these sham artists. And, specifically in certain areas of California, there's some of them that pop up, quite frequently. And we have to push legislation to get rid of those, bad actors.
And if you want payers to pay you a better rate so you can afford to provide a better clinical experience for the patient, well, it takes leadership from these organizations, in my opinion, to create an environment where the payer community looks upon the treatment provider market and says, this is a credible, like well-oiled, disciplined, industry. And therefore I'm okay investing as a payer into these higher rates, because I think it's going to get better outcomes for the patient, who in the payer's eyes is a member. They use the term member all the time. And so, and the thing is though, Pete, it takes one leader, followed by another leader, followed by another leader, that recognize that the best practices, when followed clinically and financially, make everything in the industry better.
Yep.
It just does.
And before we ruin it, Chris, we're going to let Angie take us home on this, so Angie.
Go Angie. Go Angie.
Well, first of all, for those of us in the audience who may want to contact either of you, let us know where people can find you.
So, Pete, you go to reallyimportantperson.com. No, I'm kidding.
Yeah.
I'll give you mine. So our company is finpay.com. That's F as in Frank, INPAY.com. Obviously, put the www in front of it. My personal email is actually even easier. It's my two initials, CW, Chris Wolfington. So CW@finpay.com. And I welcome any questions, comments, good, bad, or ugly, or indifferent. I actually love these kind of discussions, Pete. So anyone in your audience that just wants to have a conversation like this, I love it. So I eat, breathe, and sleep this stuff.
And for me, you can find me at pete@ccapp.us and check out the website. So thank you, Angie.
You're also at pete@nbhap.org.
No way. See what I mean? He has so many more impressive letters after his name. And we also, Pete, I don't know if you've ever said it, we have a blog that we put out on a monthly basis covering all sorts of topics. As I said, there's ripple effects, so we cover all of that. If you go on to FinPay's LinkedIn page, you can see those, or onto our website, you can also access them.
Great. You've been listening to Destination Change. Our guests today were Chris Wolfington and Pete Nielsen. Thank you for being here. Our theme song was Sun Nation by Kitsa and used via Creative Commons license by the Free Music Archive. Please consider rating and reviewing the podcast on Apple Podcasts so we can get more listeners. In the meantime, you can always see more about the podcast, including show notes and where else to listen, on our website, www.nbhap.org. If you have questions for the podcast, please email us at info@nbhap.org. Thanks for listening.